So we move on to the academic session, and for the first session, it's on pulmonary, the second part of pulmonary function test. He has already laid the foundations of pulmonary function test by his first class that was 2 weeks back. So over to Vinodhan sir for his lecture on pulmonary function test. Over to you, sir.
Vinodhan sir, please unmute.
Yeah, good evening. Yes, thank you, Dr. Shamshad, Paul, Raphael, Binil, Vijesh Venugopal, and Dr. Rajesh for introducing this topic of discussion to me. Mainly, it made me read quite a bit more about what I didn't know actually. So I am trying to convey to you quite a bit of things which I learned recently also in this lecture, because the last lecture was something primarily simple ones, which most of us have gone through earlier also, but some of the things that I touch upon this time was something even new to me. So I'll try and make it as simple as possible. Some of them may be a little complicated to you. In case you have any doubts, please ask me questions. Last time, am I sharing this?
Yeah, you're sharing slideshow.
I have a problem because
Start the slideshow, that's all.
yeah, but you're okay. Yeah, I know. What happened is all your photos are coming in the lower part, so I didn't know how to do it. Okay.
Yeah, no, just
now it's perfect.
Okay. So last time we talked about mainly the mechanical functions of the that can be actually tested, and then this time we'll go to the other part that I'm going to touch upon, mainly the parenchymal function, gas exchange, and the cardiopulmonary interaction. We also touched upon an algorithm by which you can classify the pulmonary function in that patient into obstruction, normal spirometry, pure obstruction, restriction, and mixed obstruction and restriction, and also found that some of them actually have something called as pseudo restriction, and we found out how you can actually come to a diagnosis of this by going through 3 steps. The first being to find out whether there is an obstruction. Secondly, that is looking at the FEV1 by FVC ratio, and secondly by looking at the FVC, and thirdly looking at the TLC or the slower vital capacity. So the remaining test in the mechanics is the FlowVolume Loop, which is something very interesting. So I'll take some time to tell you more about this. FlowVolume Loop is a plot of inspiratory, which comes below, and the expiratory, which comes above the y-axis, against volume, which is plotted on the x-axis. And this again is something that you record during the performance of maximally forced inspiratory and expiratory maneuver. The patient is instructed to take a full inspiration to total lung capacity, then exhale forcefully and completely into the mouthpiece to the residual volume, and then inspire forcefully and fully back into the total lung capacity. This is the last part, that is inspiring forcefully and fully back to the lung capacity, to the total lung capacity, is something that we didn't do when we are looking at an expiratory spirogram. And typically, this has to be requested specifically as an order for spirometry. Otherwise, most of the lung function labs will not do this. The normal expiratory portion of flow volume curve is characterized by a rapid rise, an explosive rise to the peak flow rate, and then a rapid or nearly linear fall as the patient exhales towards the RV. But inspiratory curve is, in contrast, a relatively symmetrical. You can see it is a symmetrical one, and it is saddle-shaped in curve, in shape, and the flow rate at the midpoint of vital capacity. That is this. The midpoint of vital capacity is known as flow 50. So you have a forced expiratory flow 50, forced inspiratory flow 50. And the ratio of this is important, and this ratio is usually less than 1. It's usually about 0.8 to 0.9. But this will actually tell you something about the where obstruction is. So flow volume loops, by and large, is the graphic analysis of flow at various lung volumes and measures forced inspiratory and expiratory flow rate. And most importantly, it identifies the probable anatomical location of the obstructive flow. This is described in these 3 distinct patterns by Miller and Hyatt way back. He divided them into variable extrathoracic obstruction and variable intrathoracic obstruction and fixed obstruction. Recently, people have started looking at the area under the expiratory flow volume curve, the AUC software, to identify the obstructive and restrictive and mixed pattern. But remember, the flow volume loop is an insensitive test in one way, because the upper airway obstruction, to be apparent, the tracheal lumen has to be brought down to almost 8 millimeter. That is almost about maybe even up to more than 50% before abnormalities can be detected. So this is what I told you. And remember, I told you in the last lecture itself that the first 1/3 of the expiratory flow is dependent on your effort, but the final 2/3 is effort independent. And this is one important part you should study when you look at the flow volume loop. And the inspiratory curve is entirely effort dependent. And the ratio, as I showed you, MVF divided by MIF is can be usually less than 1, but it can go up in certain conditions. One of this is the dynamic extrathoracic, intrathoracic airway obstruction. In this, you can see in this left panel that during expiration, this is the intrathoracic obstruction. During expiration, you will see the lung, which is got a higher pressure inside, will compress the trachea further, and thereby increases the intratracheal pressure, and this will worsen the obstruction. Whereas during inspiration, it pulls it slightly away, and that way actually the obstruction is relieved. Because of this, if you look at the curve, you will see, you compare it with the normal here. The upper portion, that is the expiratory curve, actually becomes rounded at top. It doesn't reach the peak at expiratory flow. It gets rounded. And if you look at the FEF 50, FEF by FIF ratio, that ratio, you will see that it becomes much less than 0.8 or 0.9, which is normal. And that is a definite sign that there is a intrathoracic variable or dynamic or non-fixed intrathoracic obstruction. This usually happens in tracheomalacia, polychondritis, tumors of the mediastinal trachea, or main bronchus. Whereas when it is an obstruction which is extrathoracic, you will see that during expiration, there is actually a reduction. During expiration, actually, the obstruction becomes less because inside the trachea there is higher amount of pressure, and because of that it pushes out the obstruction, and thereby the amount of obstruction is reduced. Whereas during inspiration, the tracheal pressure comes down, and because atmospheric pressure is outside, it actually can produce an increase in the obstruction. Because of this, here, if you see the curve, when you compare with the normal, the expiratory curve is almost same, or maybe sometimes a miniature of the normal, and there is a definite reduction in the FIF 50% because this curve becomes reduced. And because of this, you will see that the FPF divided by FIF ratio becomes very high. It can be usually about around 2 or sometimes even up to 5. This variable dynamic non-fixed extrathoracic obstruction occurs in bilateral and unilateral vocal cord paralysis, cervical tracheal stenosis, chronic neuromuscular disorders, the airway burns, and obstructive sleep apnea. Then you have the fixed obstruction, where there is a constant airflow limitation, both in inspiration and expiration. As you see here, both are actually blunted, both are brought down, and this ratio, FIF ratio, remains almost same. It may be somewhere around 1 almost always. So this happens in benign strictures, goiter, endotracheal and neoplasms, bronchial stenosis. You can also see some different patterns of flow volume loop, especially when you have a extrathoracic or thoracic obstruction at the thoracic inlet. Here, what happens is the variable flow volume loop obstruction at the thoracic inlet shows a double hump. Because during expiration, it gets pushed out, during inspiration, it gets pulled in. So because of that, towards the end of the expiration, it gets pushed up, and then you may have a second hump. And during inspiration, actually it gets better, and because of that, it doesn't usually affect the inspiratory curve. The same thing can happen if you turn the head to one thing. When you turn the head in a flex position, actually the expiratory obstruction becomes small. And then when you turn the head, when you extend the neck, you will find that the expiration becomes better. And in tracheomalacia, you can have sometimes a biphasic narrow peak with a flat tail, or sometimes a notched expiratory loop, or sometimes an oscillatory contour for the flow volume loop. Then you have some unusual loops which can happen in functional mainstem bronchial obstruction when it becomes almost rounded like that, or maybe end inspiratory tail and a biphasic spirogram in a left mainstem bronchial obstruction. In obstructive sleep apnea, in neuromuscular diseases, in Parkinson's disease and laryngeal dyskinesia, you actually have a sawtooth pattern. And in very young individuals, you can actually see a knee pattern, that young adults, where there is a shoulder or knee, the peak expiratory flow doesn't rise to the maximum. And this pattern, which is called a knee pattern, happens usually in absolutely normal young adult. As I described in the last lecture with the expiratory spirogram, you need an acceptability criteria for these forced volume loops. This shows you that there should not be any air leak, the first second, there should not be any artifact, and there should be an upward concavity at the end of the expiratory curve. So it can be a downward concavity, which means a poor end, or you can have a cough in the first second, which again is not acceptable, or it may be a poor initial effort, which doesn't result in the full expiratory flow, or there can be an air leak. When you find that the inspiratory flow vital capacity is more than the expiratory flow vital capacity, which means there is a difference between them of more than 10% or more than 200 ml. But what is usually very striking is the obstructive diseases, which actually can produce a very characteristic pattern. You see that the height of the peak expiratory flow is less than predicted. It goes only up to this. And then the descending limb is concave. It is scalloped or scooped with the concavity more pronounced as the severity of the obstruction increases. And when you give bronchodilators, you can see that that curve becomes slightly better. And when this increases, and in patients with emphysema, when the loss of supportive tissues happens, the airways tend to collapse significantly, and you get a typical dog-leg appearance. In parenchymal diseases, especially in ILD, you can have a witch's hat appearance. Again, this is because a steep slope and reduced mid-expiratory flow rates. You can, in typical chest wall restriction, you actually get a miniaturized expiratory pattern. It is almost it is similar to the normal, but then it becomes miniaturized. And in neuromuscular disorders, you see that PF does not go up, it's not sharp, and there is a reduction in the volume, in the vital capacity. So when you look at it, you should be able to look at these curves and then come to a prediction of what exactly you are looking at. And for that, actually, you should look at these and then memorize them. So remember these 6 patterns, and these are the most common things that you will be asked in your exams. So you remember this. This is a normal. This is the one obstructive where you find it, the PEF doesn't reach the maximum, and you have a scalloped expiratory curve. And the restrictive, where it is almost like the normal, but it's miniaturized. And extrathoracic atrial obstruction, you see the inspiratory part is brought down from the normal, and in fixed airflow obstruction, you see both sides come down. And in neuromuscular weakness, you always almost like a spherical pattern. The same thing for you to again think about it and make sure that you can identify them. This is a normal, this is a variable extrathoracic obstruction, this is the intrathoracic obstruction, this is the fixed obstruction, and this is the obstructive airway disease. I hope you are clear with it. In bronchial asthma, you see the same thing, but you will find that in bronchial asthma, when you give bronchodilators, it will become almost normal. Whereas in emphysema, it will not become normal. It will, to an extent, it will improve, but then it will never become normal. This improvement in FE1 is usually at least by 12 to 15% or 200 ml in asthma. The remaining tests are of mechanics is mainly the maximum inspiratory and expiratory lung pressures, and these are actually to find out whether the muscle strength for respiration is adequate. You have pressures like maximum inspiratory pressures, maximum expiratory pressures, sniff negative inspiratory force, the maximal inspiratory mouth pressure, the PI max, and maximal expiratory mouth pressure. These are mainly used to check the respiratory muscle strength, especially in motor neuron disease. And because they have very poor muscle strength, usually what is usually done is the sniff negative inspiratory force. In patients with motor neuron disease, a sniff pressure of less than 40 centimeters of H2O it shows you that there is a hazard risk of median mortality of 6 months. That means they don't live even up to 6 months once you diagnose this. The normal PI max is minus 80. The PE max is usually more than 80 centimeters of water, and PE max is of less than 50. Again, shows you that he will not be able to cough adequately and bring out his respiratory secretions. So let's go on to a gas exchange function. One of the common things that we can do even using a ABG is the alveolar arterial oxygen tension, and that is a sensitive indicator of detecting regional VQ inequality. The normal value in a young adult at room air is about 8 millimeters. That means the difference between alveolar oxygen, the P within the PaO2, that is the PaO2 minus PaO2, is about 8 millimeters in a normal young adult breathing room air. But it can go up to even 25 millimeters of mercury in your age decade. The usual calculation in this is that 0.27 millimeters per year, that is about 2.7 millimeters in a decade, is the decrease in the PaO2 in individuals attaining higher and higher age group. Abnormally high values at room air is seen in asymptomatic smokers. So if you find otherwise asymptomatic patients having a decreased PaO2 and increased air gradient, you should think of that patient having a small airway disease, most commonly because smoking. How do you calculate it? You calculate the get the PaO2 from arterial PO2 from that is the ABG. The alveolar O2 is usually calculated from the alveolar gas equation, which is PaO2 is equal to Pb minus PH2O into FaO2 minus PaCO2 by respiratory quotient. This is something that you must have all read in physiology. The second method of measuring gas exchange function is the DLCO. This is a diffusing capacity for carbon monoxide, otherwise known as DLCO, which is expressed in ml per minute per millimeters of mercury, or this is also called transfer factor of lung for CO, the TLCO. This is expressed in millimoles per minute per kPa. And this is the one which is used in Europe. The other one is used in US. This actually tells you the rate at which gas enters the blood divided by its driving pressure. This is a gradient between alveolar and end capillary concentration. And this has to be actually picked up by a rapid responding gas analyzer. If the gas analyzer doesn't respond rapidly, you will not be able to calculate it correctly. But what is important that it actually measures the ability of lung to transport inhaled gases from the alveoli to pulmonary capillaries and to hemoglobin. The normal is about 20 to 30 ml per minute per millimeters of mercury, but usually it is expressed as a percentage of the predicted. And it depends on surface area and thickness of the alveolar capillary membrane. And also, because hemoglobin is the one which absorbs it, it depends on the hemoglobin, and it also depends on the amount of blood which is in the lung at that particular time. So it depends on the cardiac output. So DLCO is PSCO minus alveolar, P alveolar CO minus P capillary carbon monoxide. So the usual calculation for DLO2 is almost multiply DLCO by 1.23, gives you the diffusion of capacity of the oxygen. There are many other abbreviations that I use, DLCO and DLCO-C, that is the corrected DLCO, the corrected for the hemoglobin. So when the hemoglobin goes up or down, you can correct it, and that is what is expressed. So you can correct it for the hemoglobin. DLVA is the DLCO corrected for volume, and that actually is DLCO by volume, which is also the transfer factor. DLVC is the DLCO corrected for both volume as well as hemoglobin. Now, how do you do it? This is done by using CO, which is taken up, and that is determined by the infrared analysis. Why do you use carbon monoxide? Because carbon monoxide binds hemoglobin 210 times more efficiently than oxygen. And in normal condition, there is no carbon monoxide in your blood, and even in the lung, there is no carbon monoxide. So concentration is nil both in blood as well as in lung, and it binds most efficiently to the hemoglobin. So it is done by patient inspiring a dilute mixture of 0.3% carbon monoxide in 10% helium or sometimes 3% methane, and the remaining will have 21% oxygen and about 79% of nitrogen. Once the patient takes this mixture, he takes it inside and then fills up by a full inspiration and hold it for 10 seconds. And then he breathes it out. The initial dead space gases are collected in a bag, in a reservoir bag, but the remaining one is collected in an alveolar sample bag, and that is analyzed by a rapid response analyzer after discarding the initial exhale contribution, which is from the dead space gas. This is analyzed to estimate the uptake of carbon monoxide by the alveolar capillaries. The grab sample is usually about 0.75 to 1 liter, and that is also analyzed for the tracer gas. The analysis of the tracer gas, that is the helium, will tell you the volume, that is the lung volume that the patient has got. So that gives you an idea about the total lung volume. And then from this, you can estimate the rate of diffusion of the carbon monoxide, and this change in carbon monoxide concentration is then multiplied by the single breath estimate of the total lung capacity to calculate the diffusing capacity. This is transfer coefficient is what I told you earlier. That is DLCO corrected for alveolar volume. DLCOC by volume of alveolar volume will give you transfer coefficient. DLCO is the product of surface area of lung, available gas exchange, and the rate of alveolar capillary blood and CO uptake, something that that is the transfer coefficient. So coefficient, if you look at, for example, if you look at a patient who had pneumonectomy, the DLCO will be less because the alveolar capillary blood surface is reduced. But the rate of this uptake remains constant because that Post-pneumonictomy, DLCO will be less, but KCO will be normal. If you look at this graph, you can see the helium in the sample remains constant, and from that you get the alveolar volume, and then the CO actually comes down, and from that you can see the uptake of the carbon monoxide. The DLCO predictor, percentage predictor is usually 80% to 140% of the normal, and when it is 60 to 79%, it's a mild reduction. 40 to 59% is a moderate reduction. Less than 40% is a severe reduction. It's decreased when the area of diffusion comes down, like in lung and lobar resection, bronchial obstruction, and increase in the thickness of the alveolar capillary membrane in chronic heart disease and pulmonary fibrosis and in pulmonary vascular diseases. Decrease in driving pressure again reduce the DLCO. That happens in smoking as well as in CO exposure. And when you have reduction in hemoglobin, in anemia and hemoglobinopathy, again DLCO comes down. So it can be decreased in various conditions because of this, in anemia, in smokers, in pulmonary embolism, in diffuse pulmonary fibrosis, and in ILD, in pregnancy, in severe CHF, decrease in barometric pressure, and pulmonary emphysema, the standing as well as the Muller's manner, and in chronic VTE, and when you patients who are on amiodarone, bleomycin, methotrexate. It can increase because there is an increase in the hemoglobin, as in polycythemia, or where there is an increase in cardiac output, as in exercise, in obesity, when you have left to right intracardiac shunt, when in asthma, in early CHF, in increased barometric pressure, intraalveolar hemorrhage, in supine position, and in Valsalva manner, and in chronic bronchitis without emphysema, and sometimes you find that it is increased in morning and decreased in evening. But this can be put into our logarithm that we used, yesterday. And if you add that to it, in a patient with normal pulmonary function, if the DLCO is low, then you are dealing with a pulmonary vascular disorder. In a patient with a restriction, if the DLCO is normal, then it's a chest wall or neuromuscular disorders. But if it is lower, then you are dealing with ILD or pneumonitis. In a patient with obstruction disorders, when it is normal, then you have a patient with asthma and chronic bronchitis. Or when it is less, when it is low, then you are dealing with asthma and chronic bronchitis. When it is low, you are dealing with emphysema. Then we have this split lung function, about which there was some talk last time. Dr. Murthy wanted to know why bronchospirometry has gone out of fashion. So that is why I looked up. So the split lung functions are done so long back by bronchospirometry by Paul Fechner and Stig Jochman. Way back in 1936, they presented this paper, and then they actually what they used is a Carlin's tube, and then measured one by one the volumes and the capacities of each lung. This is a thing of the past, mainly because the fact that it is difficult to do this in young individuals or even deceased individuals when they are put through a really rigorous test. So, and newer methods have taken over. One of this is the quantitative CT map showing functional lung volume, that is FLV. So with this, you can actually see, in this you can see the functional lung volume is the gray colored one. This is the gray color, is functional lung volume. This is the emphysematous areas, and this is the heart, and this is a tumor. Okay, so you can actually use a software, and the software actually will give you the functional lung volume which is available in the lung, and you can check the preoperative. You can actually compute with this the postoperative predicted postoperative FEV1 when you multiply the preoperative FEV1 from by the formula that is using 1 minus regional FLV of the lung or lobes to be removed divided by the total FLV of the lungs, you actually get the predicted postoperative FEV1. So that is one method. The second method now being used is using the radionuclide test. With that, you can actually find out the predicted, again, looking at the regional radioactivity counts of both the lungs and lobes to be removed, and dividing it by the total radioactivity counts of both lungs, you can again find out the predicted postoperative FEV1. So both these methods actually have overtaken the bronchospirometry. That is why nobody talks about it these days. Then you look at the cardiopulmonary interaction. There are cardiopulmonary exercise testing, the 6-minute walk test, the stair climbing test, and the shuttle walk, that is the ISWT and the ESWT, incremental shuttle walk test, and the endurance shuttle walk test. The exercise, okay, the exercise test should be is indicated in all patients undergoing major thoracic resection, especially when the FEV1 or DLC is under 80% of the normal values. The standardized symptom-limited stair climbing test is a cost-effective test and should be the first-line functional screening test. Shuttle walk test distance underestimates the exercise capacity at lower range and could be used only as a screening test. So a patient walking less than 400 meters may have a VO2 peak of 75% of the predicted value or 50 ml per kg per minute. The basic cutoff values for peak VO2 is peak VO2 value of 20 ml per kg per minute or 70% of the predicted value qualifies for a patient to undergo pneumonectomy or any major procedure. When it is less than 35% or less than 10 ml per kg per minute, it is a high risk for any kind of resection or any major surgery. The evidence is thin to recommend any value for lobectomy or a surgery which is intermediate. How do you do it? The test is usually done with a ergometer. So this is a machine which is used. It is a Jagger machine which has got a ergometer, which is a cycle, and this cycle ergometer, along with a blood pressure monitor, a volume sensor, a pneumotachograph, and a rapid gas analyzer, a 12-lead ECG, and a pulse oximeter, gas analyzer, and a display of breath by data and the exercise ECG. So it actually gives you a 9-plot panel. And these plots are something used to find out various things from the graph. So the graphs are of this. Some of the graphs are involved, like the graph panel 2. Panel 2 will give you oxygen pulse, which actually is VO2 divided by heart rate, and it represents the product of stroke volume and the arterial venous oxygen difference. Then you have the panel 3, and which will actually give you the VO2. the panel, it's a panel 2, which gives you the panel 3, which gives you the VO2. Panel 2, if you look at it, the panel gaps, this is the red one is the oxygen, oxygen uptake, and then that actually the VO2, this VO2 actually goes up along with the exercise. As the load of the exercise increases, you look at this is the maximum. It's not actually the maximum, it is a peak which is measured. Maximum is VO2 max is usually not actually done. It is done only in very healthy individual. The normal patients, you actually stop the exercise, which is you predict the exercise that the patient can undergo and then stop it when you reach that. And then you get the VO2 peak. And then you look at the VO2 peak. Like in this patient, it's a VO2 peak is 38 ml per oxygen per kg per minute, which is much more than what is necessary for us. What you need is more than 20 ml oxygen per kg per minute to undergo a major surgery. This is another thing that you can get from this graph, from the panel 5 and 6, that is the anaerobic threshold. The anaerobic threshold marks the onset of anaerobic metabolism as a result of inadequate oxygen delivery, and it's not altered by patient effort. It is a marker of combined efficiency of the lung, heart, and circulation. It is usually reached halfway through an incremental exercise test. You can see that it reaches the 80 anaerobic threshold. What do you mean by anaerobic threshold is that at this time, the aerobic metabolism stops and anaerobic metabolism starts because oxygen supply is not adequate. And when that happens, what happens is the carbon dioxide, the lactic acid is produced, and lactic acid is buffered, and when you buffer it, you produce more carbon dioxide. And because of that carbon dioxide, the expired carbon dioxide will increase. That is what is measured in this method is called a V slope. So you draw the carbon dioxide curve, and then you see that suddenly the curve changes. The curve from this changes to another slope. The slope changes. That is a point, you know that there is an increase in the carbon dioxide output, and that is called the anaerobic threshold. That tells you that at this time, the anaerobic metabolism has started. Same thing can be seen from panel 6, where you see this oxygen. This is the red one is the V by VO2. The blue squares are the V by VCO2. And there is a point at which both will cross. The V by VO2 will go up, whereas the V by VCO2 will remain same. The reason is that the VCO2 actually increases because there is a disproportionate rise in volume expired compared to the VO2, that is oxygen consumption, whereas the carbon dioxide production as well as the minute volume will remain almost in the same ratio. That is why it crosses. So that crossing time, where it crosses, is again anaerobic threshold. So these are three things that this gives you. That is the anaerobic threshold, which should be more than 11 ml per kg per minute. The maximum oxygen utilization or the peak VO2 should be more than 20 ml per kg per minute. The ventilatory equivalent of oxygen should be less than 35 ml. The ventilatory equivalent of CO2 should be less than 42 liters. And oxygen pulse should be 4 to 6 ml per heartbeat. So from this, the stair climbing and the 6-minute walk test and the VO2 max, you can actually find out how good is the exercise tolerance and the exercise performance. The 5 stairs, if you climb 5 stairs, the problem with the stair climbing was that there was no uniformity in the stairs. So instead of that, now we actually look at the amount of meters, the height that has been covered. So 5 stairs is equal to 22 meters, the 3 stairs is equal to 14 meters, and 1 stair is equal to 4 meters. So 5 stairs or 22 meters is equal to a VO2 max of more than 20, and the inference is that FEV1 is more than 2 liters, and low mobility is there with after pneumonectomy. And 3 stairs, that is 14 meters, the VO2 is equal to 15. Okay. And there is low mobility after lobectomy, but not pneumonectomy. 2 stairs is equal to 12 VO2 max, and 1 stair is equal to less than 10 VO2, and that actually tells you that there is a very high mortality in these patients. When you do a 6-minute walk test and the patient does more than 600 meters of distance, you know the VO2 max is more than 50. So that means this patient can be taken up for a surgery like lobectomy, but may be a poor specimen for a pneumonectomy. There are also new methods which are available, like the impulse oscillometry, which is a non-invasive, safe, and simple method of quantifying airway inflammation. And in chronic persistent asthma, it can be used to assess the potential. I'm sorry. I'm talking about fractional exhale NO, that is FANO. That is a non-invasive, safe, and simple method of quantifying airway inflammation. And in chronic persistent asthma, there is inflammation, and because of that, FeNO will be higher. And because of the high values, you know that this patient has got active asthma, active inflammation in the respiratory, and needs actually it really needs corticosteroid inhalation. The other thing is as I told you, the other one is the impulse oscillometry, which is using sounds of low frequency. When you use sounds of low frequency, it travels to the lower airways and are reflected, whereas the higher frequency will actually reflected from the higher airways. So the magnitude of change in reflection of sound indicates a pathological changes in the reflecting tissue. So this permits passive measurement, and hence can be used in uncooperative and those unable to perform spirometry. So it can actually be better at diagnosing distal airway disease and early asthma. It can differentiate between small airway and large airway changes using this. This is a technique which is coming into vogue, not available in most of the places. Now, looking at children, in more than 6 years, you can use the adult algorithm. And FE1 by FVC ratio, normal should be more than 80% in children, because they usually have enhanced elastic recoil of the pediatric of the lungs, and because of that, FE1 by FVC ratio should be more than normal. It should be more than 80% to be normal. And the global lung function initiative preference equations are available, and that actually gives you the equations for each and every different age groups. In newborns, rapid thoracic compression technique and rapid volume and rapid thoracic compression technique are used. These are again things which are coming into vogue. These are available only in certain very sophisticated institutes. Then to talk about what happened, what produced problems for us because of COVID, you should know that recommendation is that spirometry and other PFT should be limited to patients in whom results are essential to immediate management decisions, and use of nebulizers to administer bronchodilator or methacholine for testing should be avoided, and measures to prevent the spread of COVID-19 should be used and should be brought to a testing room, avoiding queues and grouping of the individuals, and the equipment should be fitted with single-use mouthpiece and disposable line and bacterial and viral filters, and enhanced cleaning and of the testing area should be performed between the patient, and ideally this should be done in a negative pressure room with at least 6 air changes per hour. So an anesthesiology role is to, and goal is to identify patients at risk of increased postoperative morbidity and mortality in thoracic patients. That is why special attention has been given to finding the right patient for thoracic surgery. So you want to identify patients who need short-term or long-term postoperative ventilator support, and to find out whether lung resection can be done in this patient, which can produce postoperative inadequate gas exchange, pulmonary hypertension, and incapacitating dyspnea. So you actually estimate this by looking at the postoperative difference that happens in the FEV1 or DLCO. The estimation of this residual lung function should be calculated based on segment counting, and only the not totally obstructed segments. The obstructed segments should not be taken into account. The only not totally obstructed segments should be taken into account, and patency of bronchus should be ascertained by bronchoscopy, and segment structure should be ascertained by CT scan. There are initially we looked at the lung lobes and the 19 segments in total. So when you look at it, the right lung has got 3, 2, and 5, so altogether 10 segments, and the left lung has got 9 segments. So the calculation used to be depending on these segments, and the PPO FEV1 or PPO DLCO was calculated looking at this particular method. So that is pre-op FEV1 or DLCO into number of segments left after resection divided by 90 will give you the post-operative predicted FEV1 or DLCO. So in a patient with a 57-year-old man with FEV1 of DLCO, both at 50%, let's say, coming for lung resection for a large RU, right upper lobe mass, confirmed with carcinoma, you can calculate that PPO FEV1 or DLCO is equal to 50 into 16 by 19, that is 42%, which is just above the mark where you will start refusing lobectomy. This was changed by Slinger and Johnson in 2005, when they actually proposed that you can actually divide these segments into sub-segments. They are actually called as functional sub-segments. And he showed that there are actually 42 functional sub-segments in the lungs, 6 plus 4 plus 12 on the right side, that is 18 plus 6, isn't it? And 22 on the right side, and 10 plus 10, that is 20 on the left side. So altogether 42 sub-segments, functional sub-segments. So here he calculated the predicted postoperative FEV1 by counting the number of sub-segments to be removed. And the calculation was again using the same formula. And then if you look at in a patient with right lower lobectomy, 12 segments are to be resected, then it will be preoperative FEV1 percentage into 1 minus 12 by 42, that is almost 100 minus 29%, that is also can be taken as 30 by 42. So pre-op pre-op FE1 into 30 divided by 42 will actually give you the post-operative FE1. When it is less than 40%, you know these patients are for at high risk for resection. So the usual interpretation is more than 40% of post-operative predicted post-operative FE1. More than 40 is no or minor respiratory complications are anticipated. When it is less than 40, likely to recur post-operative ventilation or increased risk of death or complication. When it is less than 30, non-sensory management should be considered because it is a very high risk that you can get into when you operate on these patients. Same way, when you look at its predicted post-operative DLCO, when it is more than 40%, then you know that it's an intermediate risk, no further investigation needed. But if it is less than 40, you need, you know that there is increased respiratory and cardiac mobility, and further investigation and are needed. If it is less than 40, and also the FE1 predicted also is less than 40, it's very high risk and recur cardiopulmonary exercise test to further check whether the VO2 max and the anaerobic thresholds are normal. So they have further proposed a 3-leg stool for pre-thoracotomy respiratory assessment when you look at all the 3 functions. That is looking at the respiratory mechanics, the cardiorespiratory reserve, and also the lung parenchymal function. So respiratory mechanics are looked at by looking at the FEV1 and predicting the predicted postoperative FEV1. If it is more than 40%, then you know that this patient is not at a very high risk. You can also look at the maximum voluntary ventilation or the MPC and RV by TLC, and also look at the FVC percentage. Cardiopulmonary reserve is tested by looking at the VO2 mass using the cardiopulmonary exercise test. And if it is more than 15 ml, you know this patient can pass through the most of the procedures. If it is more than 20 ml per kg per minute, then you can be sure that he will go through a pneumonectomy without any problem. This can also be done when you don't have this sophisticated machine. You can again use stair climbing. If it is more than 2 flights is what they said, but it's better to take it as more than 3 flights when you know that it is the VO2 max is more than 15 ml per kg per minute. And if the 6-minute walk test is, he'll be able, if he's able to do more than 600 meters, then again, you know that the VO2 max is more than 15 ml per kg. And if the exercise SpO2 done during shuttle test is again less than 4%, that is the reduction in SpO2 during the exercise test is less than 4%, then you again know the cardiorespiratory pulmonary reserve is fairly okay. Then you look at the lung parenchymal function, looking at the DLCO. If it is more than the predicted postoperative DLCO is more than 40%, and you also know that VO2 is more than 60 and the PaCO2 is less than 45, you know the lung parenchymal function is fairly okay. You can take this patient for lung resections. They also propose that looking at this 3-leg stool, you can actually predict the post-thoracotomy anesthetic management. If the patient is in the first category, that when everything is more than 40%, then you can excubate them in the operating room, especially when the patient is awake, that is alert, warm, and comfortable. If it is between 30 and 40%, it's a gray area. So the extubation should be based on exercise tolerance, DLCO, VQ scan, and associated diseases. If it is less than 30%, you should think of a stage weaning from the mechanical ventilation. and consider extubation if it is more than 20%. That is, if it is between 20 and 30%, you can consider extubation in the postoperative period, provided you have thoracic epidural analgesia. So, in these two lectures, I told you most of the things about pulmonary function test, but remember they help only as a support and not and to exclude a diagnosis. But it is not the only thing that you should look at. You should always look at the combination of a thorough history and physical examination, as well as supporting laboratory data and imaging, and then only make and develop a anesthetic plan for the patient with pulmonary dysfunction. Thank you. And lastly, as I put it up last time also, I welcome you as a chairman of this conference. I welcome you to the SARC AA 2022. This is the 14th International Congress Anesthesiology. And this has come to India after almost 12 years. It may not come to India anymore because most probably the SARC is going to be abolished, and it is going to be BIMSTEC which is going to come. So this is your last chance to have an international conference in India and in Kerala. So please make this opportunity, and then you should actually take the early bird challenge, and then that is available up to April 30th. So the early bird registration is possible up to April 30th. So I welcome all of you to this Congress. Thank you.
Thank you, sir, for the presentation, and you have taken the trouble of presenting it in two parts, from the basics to advanced pulmonary function test and the interpretation of the pulmonary function values and its significance in anesthesia. Now the session is open for questions. I can see one question in the chat box, sir. Can you see that, sir? What is the regulatory equivalent of oxygen carbon dioxide?
Ventilation equivalent of
O2 and CO2.
Yes. Can I go back to the slide?
Yes, sir, please.
I'm not able to do that. I had that slide in that thing. That's what I'm trying to get to. Give me some time.
So this is of practical importance for students appearing for the after their theory exams, because
can you see the slide now?
I can't see, sir. You can see that SARC 2022.
You can see that, no?
Yeah.
Okay.
Yeah, it's now going back.
Yeah, this is the you are talking about this. Okay, this is a V by VO2. That is the what we have been talking about. That is the ventilatory equivalent of carbon dioxide and the ventilatory equivalent of oxygen. This is actually calculated in the CPET as VE by VO2 and VE by VCO2. So that is in liters. Okay. So if you look at this, this is 32 liters is the maximum, and here it is the look at this. This is again 32 liters. So that tells you that the in cardiopulmonary exercise testing, the ventilatory equivalent of oxygen and ventilatory equivalent of CO2. That is what is given by the CPT. It's again taken from this 9 plot panel. It's slightly confusing when you look at it, but unless you work with it, you will not understand it fully. But these are the four important things that you have to visit: panel 2, panel 3, panel 4, 5, and 6. If you interpret these four, actually all the important things for the anesthetist is over. This is the panel which gives you VA by VO2 and VA by VCO2. I hope that satisfies the query.
So there's another query. I think it's from the YouTube. Nitrous oxide washout technique. Nitrogen washout technique for restrictive lung disease.
Nitrogen washout test. That is to check the total lung capacity, isn't it? I think I briefly mentioned in the last lecture about that. That's there are two methods. That is a single breath nitrogen washout and multiple breath nitrogen washout. Those are the tests which are used to actually check the total lung capacity. So if you want to measure the TLC, you use either single breath nitrogen washout or a multiple breath nitrogen washout. Usually what is done is single breath nitrogen washout. I think I mentioned the last thing. I had a slide on that.
Just mentioned last time.
Because it is we dealt with the volumes in the last lecture. So there actually the patient the person sits in a chamber and then he takes a breathes in the nitrogen and then he washes out the mixture of nitrogen as well as the oxygen, and then from that you find out what is that, and he breathes out. Okay, he takes out the oxygen, he breathes oxygen and washes out the nitrogen in the lungs, and then that particular sample is collected. From that, the amount of nitrogen is calculated, and then from that you find out the TLC.
So what's the protocol in the present COVID scenario? It's over. I hope it is over. About doing the PFT regarding the maintenance of the system. Yeah, you have mentioned it.
I mentioned it. That is ideally you should have negative pressure rooms with at least 6 air change per hour, and then there should be close between patients for at least 20 minutes, and then you wash it up, clean the area, and then you use single-use mouthpieces and disposable inline bacterial viral filters, and there should not be any grouping or queuing, and you should use the usual hand hygiene and personal protective equipment for the patient as well as the healthcare professionals. You should not use bronchodilators in the thing. So nebulizing in the room is not recommended. And unless it is really essential, don't do this test. That has been the recommendation.
Okay, sir. Nowadays, even the pulmonologists are very reluctant to do the PFT.
Yeah, well, the one thing that is, other than the mechanical aspect, because most of the pulmonary function labs don't give you DLCO. If you have DLCO, definitely it helps. But the other ones, like this mechanical functions, it doesn't really, not necessary unless you want to prove that there is a, after bronchodilator, there is an improvement. That's probably the only thing that can be really gained for routine pulmonology patients. So that is why I think they are not really initiating any pulmonary function tests, especially during this COVID era. And most of this can be other things, mother functions can be done by a CT scan or MRI.
Okay. So if there is no more queries, we'll go to the second part. But before going that, just a reminder of the next, that 16th, April 16th program. That is clinical and radiological assessment of pulmonary airway assessment for anesthesiologist by Dr. Amit Kohli, who is the professor at Maulana Azad Medical College, and which will be followed by PG update. Over to Dr. Binil for the PG corner.
Thank you, Dr. Rajesh.
Thank you once again, sir. Vinodan, sir.
Thank you. Thank you very much for your patient listening, and hope I've covered most of it. Hope I've given you some insight into pulmonary function test.
And I thank Vinodan sir for the excellent lecture and the extensive discussions. I think sir has covered almost all the parts during these 2 lectures. Thank you, sir. And now it's my honor to welcome my HOD, Dr. Mariam Koshi Thomas, to today's PG Corner session. Madam is the professor and HOD of Department of Anesthesia, Jubilee Mission Medical College, Thrissur. Along with Madam, there will be 2 PG students, Dr. Temi Manuel and Dr. Aishwarya Joy. Over to Madam. Madam, please unmute and start.
A very good evening to all of you. Thank you, organizers, especially Shamshad Begum and Dr. Binil, for giving us this opportunity to present this evening. 2 of my final year PGs will be presenting to you this evening. Dr. Temi Manuel will be presenting on LMAs, and Dr. Aishwarya will be talking to us about Etomidate. Now over to them.
Sir, am I audible?
Yeah, you are audible and the slides are visible. Please start.
Good evening, all. My topic for presentation is laryngeal mask airways. I am discussing under the headings Introduction, Indications and Contraindications of LMA, Classification, Technique of Insertion, Advantages and Disadvantages, and Complications. Supraglottic airway devices are a group of devices that can be inserted into the pharynx to allow ventilation, oxygenation, and administration of anesthetic gases without the need for endotracheal intubation. The first laryngeal mask airway was LMA Classic, and it was introduced by Archie Brain in 1983. These are the indications of an LMA. It's used for elective ventilation. It's alternative to mask anesthesia and endotracheal tube for short and elective surgeries under GA. And it's an important part in difficult airway card. And it's used as, according to difficult airway guidelines, it's a plan B. Plan B, if there is a failure of intubation or ventilation, we can use supraglottic airway devices as a rescue airway pathway. And in case of difficult intubation ventilation, it's an intubation conduit. And in the cardiac arrest situations, it's an acceptable alternative to intubation. And it's also used as a bridge to extubation. Laryngeal mask airway consists of a hollow shaft or tube connected to a mask-like cuff designed to sit in the hypopharynx facing within the esophageal inlet. It's an alternative to both mask ventilation and endotracheal intubation. It can be easily placed. It doesn't need a specific insertion technique, so it can be used by paramedical staff and hospital staff in the cardiac arrest scenario. It is less stimulating than endotracheal intubation, but it does not provide complete protection against aspiration and does not prevent laryngospasm. These are the contraindications of laryngeal mask airway. Any patient at risk of aspiration, example, morbid obesity, patients with inadequate fasting, GERD patients, pregnancy, we cannot use an LMA. And patients with the obstruction in the upper airway due to tumors, edema, or abscesses, and patients with a restricted mouth opening due to burns or trismus, patients with a disrupted airway, and those who need high airway pressure ventilation, and patients with a reduced lung compliance or increased work of breathing as in status asthmaticus or pulmonary fibrosis. This is the classification of supraglottic airway devices. Can be classified into cuffed perilaryngeal sealers, cuffed pharyngeal sealers, and cuffless pre-shaped sealers. And this cuffed perilaryngeal sealers are divided into non-directional, non-esophageal sealing. Examples are classic LMA, flexible LMA, and LMA unique. And directional non-esophageal sealing. Examples are fast track LMA and ambu LMA. And directional esophageal sealing. Examples are ProSeal LMA and LMA Supreme. And the next classification is cuffed pharyngeal sealers. It is divided on the basis of esophageal sealing. Without esophageal sealing, it is cobra perilaryngeal airway, and with esophageal sealing, it is laryngeal tube suction, and esophageal-laryngeal combi tube. And cuffless pre-shaped sealers. Examples are streamlined liner of pharynx airway, hygel, and Basca mask. The classification of LMA based on evolution is classified into first generation, second generation, and third generation LMAs. The first generation is there will be an airway tube with a mask-like cuff. It's an airway tube and a mask-like cuff. The examples are classic LMA, LMA unique, cobra paralaryngeal airway, and laryngeal tube suction, and airway ambu. And the second generation LMAs are, it has an airway tube with a mask-like cuff and the cuff designed to improve the pharyngeal seal. The esophageal vent that allow orogastric tube placement, and it has an integral bite block to prevent injury due to bite. And it has a cuff pressure monitors also. And there will be, in some LMS, there will be a lumen that allows passage of upper GI endoscope. The examples are esophagotracheal combi tube, ProSeal LMA, LMA Supreme, hygel, laryngeal tube suction, and Oragate. The third generation LMAs include, it's with an airway tube with a mask, and it has an esophageal vent that allow orogastric tube placement. The main peculiarity is a dynamic sealing mechanism. Examples are Basca, Elisha, and 3G laryngeal mask. And now we are discussing individual types. First one is LMA Classic. This is a first generation LMA with a cuffed perilaryngeal sealing. There's no esophageal sealing mechanism. The parts are, it has a bowel-shaped mask by an oval inflatable silicone cuff which seals the larynx, and an airway tube, and a connector, and the inflation line with a pilot balloon. This aperture bars prevent obstruction by the epiglottis. It can be autoclaved and reused up to 40 times. The classic LMA is available in 8 sizes, and we select the LMA size according to the weight of the patient. If the weight is less than 5 kg, we use an LMA size of 1. If the weight is between 5 to 10 kg, we use an LMA size of 1.5. If it is between 10 to 20, we use size 2. And 20 to 30, we use an LMA of 2.5. And 30 to 50, the size will be 3. And 50 to 70, the size will be 4. And if the weight is between 70 to 100, we use an LMA size of 5. And if the weight is 100 plus, we use a size of 6. When there is a doubt, a larger rather than a smaller size should be chosen for the first attempt. The seal pressure of classic LMA is 20 to 25 centimeters of water, and the intracuff pressure should be less than or equal to 60 centimeters of water. Because the capillary perfusion pressure is 60 centimeters of water. If the intracuff pressure is more than 60, there will be a defect in the perfusion and ischemia of the mucosa of pharynx. Next is LMA unique. It is similar to classic LMA, the single-use sterile type. It's made up of PVC, has a soft, flexible cuff, and the aperture bars are designed to prevent blockage of airflow by the epiglottis. 5 sizes are available from neonate to adult. Next is LMA flexible. It's a first generation cuffed perilaryngeal sealer without esophageal sealing. The wire reinforced flexible airway tube with a smaller diameter than other tubes. It can be easily positioned away from the surgical field, and the seal pressure is 20 centimeters of water. It's more useful in shared airway surgeries like head and neck surgeries and ENT surgeries because it can be repositioned very easily. And the problems are destruction of the spiral reinforced wire, increased airway resistance, it limits endoscope and tracheal tube passage, and it's unsuitable for MRI. Next is LMA fast track. It's a first generation LMA, and the features are it has an anatomically curved rigid airway tube and an integrated guiding handle and an epiglottis elevating bar and a plexometallic endotracheal tube and a stabilizing rod. This black line of endotracheal tube corresponds to the epiglottis elevating bar. This is used as an intubation conduit, and after intubation, the LMA fast track is removed. So it not to be used as a primary airway device. Next, LMA C-track. It enables combined visualization, intubation, and ventilation. It has high first attempt intubation success rate, and it has two inbuilt fiber optic channels, one to convey the light and the other to convey the image to the viewer. And it's ideal in rescue or difficult airway situations. And the main disadvantage is it is not useful in patients with a difficult mouth opening. Next is LMA Proceed. It's a second generation LMA. It has a dorsal cuff and an airway tube. And lateral to this airway tube, it's an esophageal drain tube. And it has an integrated bite block for protection and prevents airway obstruction. And it has this pilot balloon. And this dorsal cuff makes it produce higher seal pressure of 35 centimeters of water. Next is LMA Supreme. It is a second generation LMA and it has directional esophageal sealing, reformed curved airway tube and esophageal drain tube, separate esophageal drain tube, and it has a large elliptical cuff. It has a seal pressure of 30 centimeters of water. This fixation tab prevents the proximal displacement of LMA. The newer modification is LMA Gastro. This is second generation LMA. It's anatomically shaped the airway tube and has a large bore endoscopic channel. This adjustable holder and strap will keep the LMA in position during the endoscopic procedure, and it also has an integrated bite block. Now we are moving to the technique of insertion of LMA. Select the proper size of LMA according to the weight of the patient. Inspect the LMA for any tear and blockage. The cuff should be deflated and lubricate the posterior surface of the LMA with a water-based lubricant gelling. Adequate depth of anesthesia with IV or inhalational agents is important for smooth insertion of LMA. And the technique is first LMA is held with the index finger of the dominant hand placed at the junction between the cuff and the airway tube. The cuff is pressed toward against the hard palate with the index finger, then backward and downward along the palate smoothly until the resistance is encountered. As the index finger is removed, the dominant hand pushes down on the LMA to prevent dislodgement. Inflate the cuff to a target cuff pressure of around 40 millimeters of mercury or until an adequate seal is obtained. The standard maneuver is for the insertion of intubating LMA. This maneuver will increase the seal pressure and aligns the axis of trachea and flexible endotracheal tube, and it also helps in blind intubation. There's two steps. First step, rotating intubating LMA in sagittal plane in an attempt to find least resistant ventilation position. And then the second step is to grasp the handle and use it to draw LMA forward 2 to 5 millimeters in a lifting action without lowering the teeth. If we inserted the LMA correctly, these are the signs. On LMA inflation, there will be outward movement of the tube and the presence of a smooth oval swelling in the neck around the thyroid and the cricoid region. And on manual ventilation, there will be chest rise and we can feel the back. And on monitor, we can see EtCO2 and by chest auscultation. If we inserted the LMA correctly, the mask of the LMA will be in the floor of the hypopharynx, and the distal tip of the cuff will be in the upper esophageal sphincter, and the sides of the cuff will rest in the pyriform fossa, and the upper part of the cuff will be in the tongue base. These are the advantages of LMA. It's an alternative to both mask ventilation and endotracheal intubation. It can be inserted easily, can be used for spontaneous and positive pressure ventilation, less sympathetic stimulation than endotracheal intubation. It's a rescue device and intubation conduit in difficult airway situations. Additional features for orogastric tube placement and upper GI endoscope are present. This is the disadvantages. So not a definitive airway, not offer protection against aspiration risk, not recommend in patients with a poor lung compliance because of lower seal. And if high pressure ventilation is used, there will be a dislodgement of the LMA and gastric insufflation. It is not a choice for restricted mouth opening or upper airway abnormality. In the situations, awake fiber optic intubation will be the better choice, and incidence of sore throat will be higher for LMA. The complications, most common complication is post-operative sore throat and gastric insufflation. In inadequate plane of anesthesia, there will be bronchospasm, which may lead to negative pressure pulmonary edema and aspiration of gastric contents. Trauma to the LMA itself or the surrounding soft tissue. Dislodgement of LMA can occur, and nerve injury to superior laryngeal nerve, hypoglossal nerve, or recurrent laryngeal nerve. And in inadequate plane of anesthesia, there are chances of laryngospasm also. The troubleshooting problems of LMA includes if the patient is an inadequate plane of anesthesia, there will be initial difficulty with the placement of LMA, and the chances of laryngospasm or bronchospasm, which leads to airway obstruction. Downfolded epiglottis will causes noisy ventilation or airway obstruction. If the LMA is selected as of inappropriate size, it is difficult to get an adequate seal. So larger seals create a better seal with a lower cuff inflation volumes. And if we use LMA for positive pressure ventilation, since the LMA does not seal the pharynx, the pressure that can be safely used to ventilate is limited by leak around the device, which leads to gastric insufflation or hypoventilation. So pressure support or pressure control ventilation is used rather than volume control ventilation. Pressure control ventilation prevents high peak pressures that can lead to airway gas leaks and gastric insufflation. Set the peak pressure between 50 to 20 centimeters of water and the respiratory rate according to the minute ventilation. These are my references. Thank you.
Thank you, Dr. Temi. We don't have any questions in the chat box.
Dr. Temi, hello.
Hello, sir.
So it's a reusable thing, no? LMA.
Yes, sir.
How to sterilize and use it for the next patient, and to what extent you can use it, repeated usage?
Sir, we have to clean it with the sodium bicarbonate solution, and we use steam autoclaving or ethylene oxide technique for sterilization, sir. And we can reuse up to 40 times if it is a classic LMA.
Okay. Binil?
One second, I'll allow others to unmute. Yeah, if there is any questions, they can ask now. They can unmute and ask. And senior members can give their comments also.
Tini, you presented well.
Thank you,
About
sir.
LMI. Okay. You're first year or final year?
She is the final year PG student.
Okay. All the best for your upcoming exam.
Thank you, sir.
I think there is no more questions. So we'll move on to our next topic, that is Etomidate. Over to Dr. Aishwarya for Etomidate. Madam, anything to add? I forgot to ask you.
No, nothing.
Is my screen visible, sir?
Yeah, it's visible. Please.
Good evening, all. Today, the drug we are going to discuss is Etomidate. So I will be discussing under these headings: introduction, physiochemical properties, pharmacokinetics and pharmacodynamics, uses and its side effects, and novel Etomidate derivatives. Coming to the introduction, it is an intravenous anesthetic agent. Its properties are hemodynamic stability, cerebral protection, minimal respiratory depression, favorable toxicity profile, and rapid recovery. It is available as 10 ml or 20 ml vial and doses to 10 g per ml. A little about history. It was first described in 1965 and it was originally developed as an imidazole antifungal agent. And it was introduced into clinical practice in 1972 due to its hypnotic effect, and it was used for sedation and for induction of anesthesia. And it became unpopular as etomidate caused adrenocortical suppression, and now it's widely used due to its beneficial physiological profile. Physiochemical properties: it is a imidazole derivative with a pK of 4.2, hydrophobic at physiological pH. To increase its solubility, it is formulated as a 0.2% solution, either in 35% propylene glycol or in a lipid emulsion. pH of 7. Coming to its mechanism of action, it acts on GABA A receptor. Thereby, it increases the receptor affinity for the inhibitory neurotransmitter GABA. So less dose of GABA is needed. And in supraclinical doses, it causes direct activation or allosteric agonism of GABA A receptors. And R isomer is almost more than 5 times more potent than S isomer. Coming to pharmacokinetics, absorption is by IV route. Distribution, it's large volume of distribution due to its tissue uptake. 99% unionized at physiological pH. Distribution half time is 2.7 minutes, and it is about 75% protein bound, and it processes placenta. Metabolism is by hepatic microsomal enzymes and plasma esterases, and it is metabolized into an inactive metabolite, and it has high hepatic extraction ratio. Elimination, T-half is about 2 to 5 hours, predominantly renal excretion about 85%, and other route is through bile, which constitute up to 13%. Onset of action is rapid, one arm brain circulation, that is about 30 seconds, and duration of action is 5 to 10 minutes. Rapid awakening is caused due to redistribution. Coming to the pharmacodynamics of etomidate, in central nervous system, it acts on GABA A receptor causing hypnosis. There is a reduction of cerebral blood flow by about 35%, and a reduction in cerebral metabolic rate of oxygen by about 45%, and it causes decrease in ICP. Both mean arterial pressure and cerebral perfusion pressure is also maintained, so it gives us cerebral protection. Associated with grand mal seizures and produces increased EEG activity in epileptogenic foci, and it lacks analgesia. Coming to the cardiovascular properties, effects, it causes minimal change in heart rate, stroke volume, and cardiac output. And it causes minimal depression of SVR, MAP of about 15% decrease. It has only minimal myocardial depression, so hence it useful in patients with valvular or ischemic heart disease undergoing non-cardiac surgery, and in patients with poor cardiac function. Hemodynamic stability is due to its lack of effect on sympathetic nervous system and baroreceptors, and maintains myocardial oxygen demand supply ratio. Coming to its effect on respiratory system, it has less effect on ventilation, and it does not cause histamine release. So it's useful in maintaining spontaneous ventilation. Coming to the adrenocortical effects, which is the most important side effect of etomidate, there is dose-dependent reversible inhibition of the conversion of cholesterol to cortisol. And the specific enzyme inhibited here is 11-beta hydroxylase, and the suppression may last up to 72 hours following a single bolus dose induction. It also decreases aldosterone, and so we should be cautious in its use in sepsis patients, and adrenal suppression action is more potent compared to its sedative property. Coming to its uses, induction of anesthesia by a dose of 0.2 to 0.6 mg per kg, most commonly used as 0.3 mg per kg, in patients with cardiovascular disease, reactive airway disease, intracranial hypertension, in shock patients, trauma and hypovolemic patients, in giving sedation for cardioversion, percutaneous coronary intervention, ECT, and in treatment in hypercortisolemia. There's off-label use for Cushing syndrome. and intraoperative mapping of epileptogenic foci because it enhances EEG activity in these foci. And we can also use for rapid sequence induction of anesthesia for trauma cardiogenic patients in casualty and in ICU. The side effects of Etomidate are the most important one, adrenocortical suppression, pain on injection, which can be prevented by prior administration of lignocaine 1.5 mg per kg, or using lipid emulsion, or choosing larger veins for the administration. Other side effect is myoclonus, which can be prevented by prior administration of benzodiazepine or fentanyl. Postoperative nausea, vomiting, which can be again treated with antiemetics, and emergence delirium. One of the most important side effects is it cannot be used for maintenance of anesthesia or as infusion due to its adrenocortical suppression. This is a table comparing the hemodynamic changes of effect of IV injection agents. As we already told, Etomidate causes minimal change in BP, cardiac output, and heart rate, while others causes thiopentone and propofol causes a decrease in this BP, cardiac output, and heart rate, while ketamine increases due to its sympathetic nervous system stimulation. Corticus trial, it was a corticosteroid therapy of septic shock study. It was a study done to evaluate the effect of hydrocortisone versus placebo in septic shock patients. And in a sub-study of this trial, where they evaluated 96 patients who received Etomidate within 72 hours prior to the inclusion to the study. And it was found that Etomidate was associated with an increased incidence of inadequate response to corticotropin and a higher 28-day mortality. Coming to novel Etomidate derivatives, these were developed to mitigate the side effects, the adrenocortical suppression of Etomidate. So this slide describes the derivatives and its properties. First one is carbo-Etomidate. It has a property of decreased risk of adrenocortical suppression along with decrease of postoperative nausea and vomiting. And methoxycarbonyl Etomidate, it has the property of high hypnotic potency, hemodynamic stability. It also has rapid onset and offset, less adrenocortical suppression. And it's one of the disadvantages on prolonged infusion causes accumulation of metabolites and thereby causing longer time for recovery. Other agent is methoxycarbonyl carbo-Etomidate. Again, it has the property or advantage of no suppression of steroid synthesis. It's a potent drug, it's a rapid onset drug, and one of the disadvantages is prolonged duration. And other one is cyclopropyl methoxycarbonyl Etomidate. It is 10 times more potent than MOC carbo-Etomidate and low metabolite accumulation, and it has low contact sensitivity half-time, less cytokine production, making it safe in sepsis patients. And dimethyl methoxycarbonyl Etomidate, it has low contact sensitivity time and again less suppression of steroid synthesis. These are my references. Thank you.
Excellent presentation, Dr. Aishwarya. So you have mentioned about the side effects of Etomidate, and you have emphasized on adrenocortical suppression. So what are the other side effects of Etomidate?
Other one is pain on injection, which can be prevented by prior administration of lignocaine or choosing larger veins. Then myoclonus, which can be prevented by again a prior administration of benzodiazepine or fentanyl. Then postoperative nausea, vomiting, and emergence delirium.
Any other questions, Dr. Rajesh?
Dr. Aishwarya, you presented well. Can you use it in pediatric age group? If not, why? So I have given a clue.
Yes, it is true that in children below 3 years,
Okay.
and where there is brain, where there is brain growth, in the period of brain growth, it causes neuronal apoptosis, when the surgical duration is more than 3 hours. So it causes decrease in brain, it affects brain growth, brain cell growth.
Okay, there is insufficient data to support its use in below 10 years. Okay. So what about in geriatric age group? What precaution you should take in geriatric age group?
Geriatric age group, so again, we should give an aliquots or and we should not use as infusion or for maintenance.
Because it's eliminated through renal system, you have, to be very careful because geriatric age group means there is a physiological deterioration of the renal functions. Okay, so you have to be very careful. I may have to reduce the dose itself. Okay. So you said that there is myoclonus. Okay.
Yes, sir.
So why myoclonus? So what's the mechanism?
It is due to disinhibitory action on extrapyramidal pathway.
Very good. So excellent. It's due to disinhibition. Okay. Not that it opens the seizure threshold. Okay. So what's the arm brain circulation time, or rather once you inject it, how long it will take for the patient to become unconscious?
It's about 30 to 60 seconds.
It's around 100 seconds, you can say. Okay. It will be below 100 seconds to be on the safer side. Okay. You are also exam going.
Yes, sir.
Very good. All the best. Okay. For both of you.
Rajesh sir, one question is there in the chat box. Etomidate in pregnancy.
No, it's not. There aren't adequate studies to prove that it can be used in pregnancy. So it's not used usually.
Any other participants, if there is any comments, they can unmute and they can ask.
So request all postgraduates to present the papers or posters in the
SACA
conference. Those who are not registered, you can register. Dr. Binil has put the link now. He has shared the link.
Yes, yeah, sir. Yeah, shared the
the
link
PG
in the
update,
chat box.
and it's in the PG update group also.
And moreover, we have extended our registration, early bird registration till the end of this month. So, and our abstract submission portal will be on after 2 weeks. Within a couple of weeks, it will be open. So I request all the PG students to submit the abstract and join us in the conference. It's a conference, I think, after 2 to 2.5 years after the COVID. So once the COVID started a couple of years back, when we moved to online conferences, now we are coming back to the offline conferences, so we can enjoy the physical conference in Kochi.
So next week we have clinical and radiological assessment of airway for anesthesiologists. It's an important topic and will be interesting for most of the postgraduates for practical as well as for the your theory exams. So please do attend and ask your colleagues for PGs to also to make that opportunity.
So
okay.
If there is no more questions, shall we wind up the session, sir?
Yes.
So I thank today's speakers, Dr. Vinodan, HOD of Senior Consultant and HOD of Department of Anesthesia, Medical Trust Hospital Cochin, for the excellent presentation on pulmonary function test. Actually, this presentation is available in the YouTube channel, ISA Kerala YouTube channel. Those who want to repeat the session, repeat the lecture, they can view in the YouTube channel. So there is 2 lectures, part 1 and part 2 of PFT is available in the YouTube. And I extend my sincere thanks to Maria Madam for joining us today in the evening for the PG Corner session. And I thank our junior doctors, Dr. PG postgraduates, Dr. Aishwarya Joy and Dr. Temi Manuel, for presenting LMA and Etomidate in a grand way. Excellent presentation, Aishwarya and Temi. So best of luck for the examinations. And I extend my sincere thanks to all the participants who joined us today evening. Thank you.
Thank you, Binay. Thank you.
Madam is there. Over to Madam for concluding remarks. I just
Okay,
searched now and I couldn't find it.
the juniors.